Good morning, everyone, and a very happy and prosperous New Year to everyone. Today, my topic for the meeting is anesthesia for orthognathic surgery. And since over my time here in Barron Specialist Hospital, I have had the opportunity to do cases for orthognathic surgeries, which is a privilege. And I will be sharing insights behind the drapes, what happens in orthognathic surgery, and how anesthesia is important, and it fascinates you. Thank you. So what is orthognathic surgery? So it comes from the Greek word orthos and gnakos. Orthos means to straighten and gnakos is for the jaw. So this surgery involves the manipulation and fixation of maxilla, mandible, or both. It is carried out to treat malocclusion, improve the airway anatomy, improve the oral health, normalize the facial balance, manage the obstetric sleep apnea, and in the treatment of congenital craniofacial disorders. So any anesthesia requires to know the surgery itself. It is one of the surgeries where we have to know the procedures and the steps of the surgery, and each step has its importance with anesthesia. So for the maxilla, we have the Lefort 1 osteotomy, which is the maxillary advancement or impaction. Then for the lower jaw, we have the BSSO, which is the bilateral sagittal split osteotomy, which is the mandibular either setback or advancement. Then bimax or bimaxillary osteotomy, where we are doing both of them for the double jaw surgery, which involves both Lefort 1 and BSSO. And there is genioplasty, which is the chin augmentation or reduction. So coming to surgical considerations for the maxillary osteotomy, as you can see in the first picture, this is the picture of maxillary osteotomy where the surgical incisions are played in the red line. There is down fracture of maxilla in the three planes it is occurring, and it is of importance because it is the time of maximum tissue disruption with maximum risk of surgical bleeding and even damage to the nasal tube, what we put in an orthognathic surgery. For the mandibular osteotomy, this is the B is the photo of this. As you can see, there is bilateral sagittal split osteotomy. And here the mini plate and screws are planned either for making it forward or making it little back, which is for prognathism or retrognathism for correction. So people who come for surgery, they tell us like we have a bimax surgery directly, because they are being told a bimax surgery is a double jaw surgery which involves the surgery of both maxilla and mandible, and it offers the greatest degree of jaw correction with greatest surgical duration and highest degree of blood loss also. So in Barron Specialist Hospital, over 1 year, we have done 74 cases, and 5 cases have required intra transfusion, and post-op nausea, vomiting 2 were there, and difficult extubation requiring ICU were nil, and there were re-explorations, surgical re-explorations 3. So the main challenge, what are the challenges why this orthognathic surgery is so important is the shared airway challenge, because the primary conflict is the surgeon needs the full access to the mouth. He wants the mouth to be closed at the end to check the bite, that is occlusion. But anesthetist needs to secure the airway. So how will we secure the airway? Where we have to put the tube? We have to put the tube in the nasal way. So there is a nasotracheal intubation is needed, which is a different way of putting the tube than the orotracheal intubation, which we usually do. Usually the patient profile is young, healthy, ASA1 or ASA2, but they are very anxious most of the times we have seen, and they have risk of swelling also around the jaw. So what are our goals? The goals are for having a shared air with surgeon, which requires a good communication between the surgeon and anesthetist in every stage. Second, we need a critical bloodless field for the surgical visibility. In this surgery, we have seen this is much needed, which can be achieved by what? Controlled hypotension. And at the end of the surgery, there should be rapid emergence. Patient has to be awake to protect the airway, because there is a continuous even nasal bleeding like that will be happening even post-op. So pre-op assessment, airway anatomy, patient usually come like this is a case of, as we can see, this is a forward jaw or prognathism, which needs a correction. So we evaluate for sometimes there will be low jaw and the jaw has to be made, which is That is why we have to evaluate for retrognathia or any limited mouth opening. Patient can have difficult airway due to skeletal deformities. Then there can be comorbidities like in the form of obstructive sleep apnea, which is common in retrographic patients, and of course, exercise tolerance and cardiac status. So planning starts from the pre-op assessment. When the patient comes, we have to explain to the patient like you will need a nasal intubation, and this nasal intubation plan, for that we have to check the nasal patency. How we check the nasal patency? We block the one nostril and we tell the patient which nostril you are able to feel better. So it gives an idea of whether there is a deviated nasal septum and which right nostril or the left nostril is, we can able to negotiate the nasotracheal tube. Some institutes have the plan of CT phase and nasal endoscopy reports. Sometimes they do when there is a nasal spur or they are thinking there is some syndroming, they do and give us the reports. So this is one of the most important. And another thing is that what we ask also, cross-match and type and screen and reserve blood. And if it is a biomax surgery, we cross-match and reserve 2 units blood at least. And we also explain to the patient regarding the nasal intubation after the surgery. When we explain before in the pre-op assessment only, then they are really a little more comfortable and communicating with us during the extubation phase also. So as I told, they are young adults, may have existing psychosocial issues surrounding self-image and self-esteem. So airway assessment includes the difficult mask ventilation, difficult intubation, and the planning. So coming to the airway management, the most important is the nasal intubation, which is the gold standard to allow checking of the dental occlusion. So how we do nasal intubation and which tube we use? We use the nasal ring Advin tube, which is preferred. And for the visualization, once it passes through the nose, how we visualize it? We use the Macintosh laryngoscope, the normal, our good old laryngoscope. But sometimes we have to use glide scope or video laryngoscope or fiber optic if there is a limited mouth opening. For this type of nasal intubation, how we prepare the case? Once we take the patient inside, we put drops like vasoconstrictor, xylometazoline drops to reduce the epistaxis rate. And the another most important is the Magil forceps, which is essential for guiding the tube through the oropharynx. So this is the preparation we do. As you can see, this is the tube, which is the Portex nasal tube, and it is also called North Pole. And this is another option just kept for standby cases like a flexometallic tube. And if it is difficult, intubation or nasal is difficult, and we have to immediately secure the airway, oral tube is also kept. Similarly, the normal scopes and blades, Magills, throat pack, and this Otrivin drops, airway, even nasopharyngeal airway, we have a cuff monitor and a mask. And this is the bougie also. Sometimes if it is negotiation is difficult, we do keep a bougie also. So if the intubation is, sometimes the intubation can be very difficult in cases when there is a severe malocclusion or revision orthognathic surgery or severe this temporomandibular joint pathology. So we consider in those cases awake fiber optic. Usually the cases what we found here are usually young adults who wait for up to 18 years for their dental maturity and they go for this type of surgery. So this is a nasal intubation tube, which is the Portex tube, and we have this tube, and our surgeon wants this tube only for the intubation. He is not okay with flexometallic or other tube. So this tube is mandatory for the nasal intubation because it provides unobstructed access to the jaws with minimal risk, and there is contraindication to nasal intubation if there is suspected epiglottitis, mid-phase instability, coagulopathy, and suspected basilar skull fracture. So in trauma cases, we have to be very careful. So this is our patient only. We have done this nasal intubation. As you can see the position, how it is kept in this one. And it has to be positioned because all these drapes will be covering and we don't have any access to the patient once the surgery starts. And this tube has to be placed in a padding way so that the pressure marks of the tube, the connectors are not there, and which will be helpful for the stability of the keeping the tube, because the surgery will start from this end, from the maxilla and this mandible. So, and there will be too much mobility also. So this fixing and also padding of the eyes is very, very important. And damage to the nasal tracheal tube during lateral nasal osteotomy is a recognized intra-op complication and may result in loss of ability to ventilate with ongoing blood loss. So that is a very emergency airway emergency situation, and sometimes the change of tube may be difficult, but we should try to do it rapidly as far as possible. And throat pack if balloon ruptured. Sometimes while going through the nasal tube, we have seen that the bony spur can rupture the balloon of the or the cuff of the endotracheal tube, and if it happens in the middle of surgery or while doing surgery, then if it is managed, we go ahead with the throat packing. Otherwise, we have to change the tube. So what will happen if the nasal intubation is not possible, or if the nose is also like you are going for a surgery where the nose is also involved, where we are going to put the tube? So other than the oral, the other alternative is submental intubation, tracheostomy, very rare, and retromolar intubation. So these are the pictures for this is the retromolar space. Sometimes in some patients, if it is possible, we put retromolar. This is tracheostomy, and this, as you can see, is the submental intubation. Submental intubation, the tube will be given through oral, but after that, a crease will be made in the mental crease, and with the help of a blunt forceps, and with two people, the dissection will be made, and the tube will be taken out from the mouth to the mental by disconnecting the connector and then taken out. So this is one of the alternatives which is done when the nose is also involved in surgery and they want the mouth to be free also. So coming to the intra-op management, the patient positioning is very important. A head elevation, as you can see, 10 to 15 degree or reversed Heidelberg will facilitate the venous drainage and intra-op hypotension. And we have limited access to the patient head once surgery is underway. As you can see, these are the points where the disconnection can happen even under the drapes. So we have to connect it, and we have to be hyper vigilant while total hold during the time of surgery, because we don't have access, and we have to go under the drapes if the connector is coming out, because if the connector is coming out, the oxygen will also be stopped from the patient, which is going to cause hypoxia if you are not vigilant. So how we do it? Usually our anesthesia machine will give alarm and there will be leak. We come to know that there is a something disconnection is there, and we do connect it, but we also put on these points where the junctions are disconnecting extra this plasters so that they don't come out. So ensure the ATT, as I told, is breathing circuit, everything, monitoring cables are long enough to reach the operating table, because we are almost towards the leg end of the patient. Nasal tube is taped and it should not be compressing the alar margin, which is susceptible to ischemic injury. Then, as I told, because they are cleaning the betadine with all the face and all, padding of the eyes, arms, everything is important. And usually these surgeries take 4 to 5 hours. We need a urinary catheter also. So inadvertent hypothermia and post-op shivering is common. We use forced air blanket, warmed IV fluids, and temperature measurement. How we maintain the anesthesia? There are two ways of maintaining the anesthesia, either with volatile agent or total intravenous anesthesia. Nowadays, total intravenous anesthesia with propofol and opioid is having more advantage, because it reduces the post-op nasal vomiting and reduces the risk of emergence delirium, which is very prominent in orthognathic surgeries. Emergence delirium is the phase which happens more with when we use inhalation agents. When the patient comes out of anesthesia, sometimes the patient will be very agitated, and this is more found when there is orthognathic surgeries or any airway surgery, pediatric age group or ENT surgery. We have seen these things. Also, it causes when we use propofol with remifentanil or any other fentanyl opioid, it reduces the hemodynamic changes during emergence and extubation. So these are the drugs: sevoflurane, propofol, and remifentanil. So coming to remifentanil, this is one of the most important drugs in orthognathic surgery, which is an ultra short acting opioid, and we have this one. And this is the infusion of remifentanil is a popular anesthetic technique, which is giving a very smooth plane of analgesia and anesthesia for maintaining and the hypotensive anesthesia. And it is also a component of TIVA. Nowadays, the recommended is the target control infusion or TCI pump, for rapid titration around the time down fracture. So alternatives to remifentanil, one more important drug is dexmedetomidine and clonidine, but usually dexmedetomidine is more preferred, and it is alpha 2 agonist. The most important good effect is it reduces blood loss and post-op nausea, vomiting, and also the analgesic requirements. But the extubation can be little delayed because it has a little sedative effect. This trigeminal-cardiac reflex is one of the important reflexes which happen during when there is the mandible, when the maxilla is being down fracture is done. During that time, it is highly stimulating and it can cause even bradycardia and asystole. And with any cardiac reflexes which occur during anesthesia, we always communicate with the surgeon and we tell them to release the traction or the pressure. And usually it subsides once it is done like that. Otherwise, if it is not subsiding, we go for treatment with anticholinergic like atropine. So this picture is from our operation theater only. As you can see here, there is down. 1 minute. We can see there is a down fracture done here. Leafort 1 has been done. When this procedure is done, it causes significant bleeding. When it is called significant means it is really bleeding like anything at that point, bone and soft tissue. And why it is happening? Because maxillofacial is highly vascular. There are many bleeding points in maxilla, like the pterygoid venous plexus, the maxillary artery in the pterygopalatine fossa, and the maxillary sinus mucosa itself. Even after the surgery, also from the nose, we see the patient having bleeding for some time because the maxillary sinus mucosa, all these are handled. And the surgical visibility is reduced. Once this is reduced, the surgeon finds it very difficult to operate. So that's why there is a need of controlled hypotension. So for the intra-blood loss, tranexamic acid is one of the drugs which has multiple studies and found that significantly reduces the blood loss, improves the surgical fluid, and Olson et al. Has found that 30% reduction in blood loss can be done with a single dose of 10 to 20 milligram per kg of tranexamic acid. So other than this, what can be done for reducing the blood loss? Our surgeons usually do with local anesthetic with adrenaline injection, but the dental anesthetic solutions usually contain higher concentration of adrenaline. So we have seen also, like young healthy patient, we see marked tachycardia and sometimes BP. Sometimes we feel that this is a sign of light anesthesia, but we have to judge clinically. We ask did you inject now only, or was there any blood during the injection, like that, and we confirm it. So whatever the regional block or the dose they are giving, it has to be within with adenized lignocaine, the dose is 7 milligram per kg, and usually the maximum limit is 300 microgram of adrenaline per hour, because adrenaline is a very potent vasoconstrictor. And when we use regional block with this local anesthetic, it provides preemptive analgesia. So what is preemptive analgesia? Before the surgery starts, we reduce the central sensitization of the pain receptors. So it counters the sympathetic hypertensive response to painful stimulus during surgery. So how do we achieve this hypotensive anesthesia? Nowadays, the target is 50 to 65 millimeters of mercury, and it reduces blood loss and improves the quality of surgical fluid. But the technique has to be individualized. All patients cannot be made to make 50 millimeters of mercury, or even if the surgeon is telling, my limit is 55 maximum millimeters of mercury. And 20 to 30% reduction in MAP in ASA1 patient is our safe target. Because with hypotensive anesthesia, there can be we have to care for the pressure areas. There can be skin necrosis in the patient positioning where we are securing the tracheal tube at nose, and we have to assess the patient on the individual basis. So what are the contraindications? Contraindications: if anyone is having ischemic heart disease, severe hypertension, hepatic, renal, diabetes, polycythemia, anemia, and ischemic cerebrovascular disease. Basically, any patient who can have end organ perfusion problem. And how do we monitor it? We usually, when it was started, it was first done with invasive BP monitoring. But most of the times, what we are doing now is the standard of monitoring is non-invasive BP monitoring. And unless there are, of course, specific concerns, or we feel the bleeding has exceeded and we need to monitor the BP immediately. But as we told, it is not an inadvertent hypotension, it is a controlled hypotension. So that is why we can monitor the BP and have the agents responsible and how to decrease it also. And BP depends on cardiac output and systemic vascular resistance. So this principle is applied for achieving the hypotensive anesthesia. Either we have to reduce the cardiac output or the systemic vascular resistance or block the autonomic ganglia. So how do we do it? With either reducing the contractility, the heart rate. We use drugs like beta blockers, esmolol and labetalol, and opioids like remifentanil. Alpha blockers also labetalol, calcium channel blockers. And in all inhalational agents are going to reduce the systemic vascular resistance, like most of them important being sevoflurane. We have sevoflurane, and we have nitrates, sodium nitroprusside, nitroglycerin, and some direct acting, and the centrally acting most important is dexmedetomidine. So key agents, remifentanil, as I told, and sevoflurane, beta blocker, and also this positioning 15 to 20 degree will head up will facilitate venous drainage. And we have to consider eye protection. Throat pack is mandatory to prevent blood ingestion, must be documented and removed before extubation. And fluid management, restrictive fluid strategy to reduce facial edema and replace losses judiciously. So the critical safety checklist during emergence is we have to check the hemostasis. We have to again raise the BP to within 20% of baseline, and to see if there is any bleeder or anything. And the neighbor event is the ensure that the throat pack is removed, and extubate only when the patient is fully aware, obeying commands. This is very important so that he can protect the airway. We can tell the patient there can be a bleeding going on in the back of your mouth, and just try to swallow it, or just it makes him relaxed when he is awake. So how do we do the extubation? We have to carefully and thoroughly gentle suction of the oral cavity to remove any blood, any airway secretion or clot in the postnasal space which may cause airway obstruction. If there is a chance of, nowadays we are not doing intermaxillary fixation, but if there is a chance of intermaxillary fixation, which means wiring the two upper and lower jaws, then there should be clear communication between the surgeon and anesthesiologist, because the mouth will be closed after the surgery, and the patient has to be alert and be very awake, because we cannot immediately reach the airway. So this is one of the tricky situations, and sterile scissors should be available during extubation and PACU. But in our place, we are not doing IMF. Our surgeon is keeping the mouth open, and he is using the elastic braces, or the bands after the surgery is over. So for extubation, it has to be awake extubation. We have this beautiful drug, sugammadex, or which can totally antagonize the effects of rocuronium. And we explain to also the patient there will be risk of ongoing bleeding to the upper airway. And the desirable response is smooth controlled emergence with either remifentanil or dexmed. Fortunately, nasal tubes are tolerated well. Sometimes we have to just lift up to the and bring up to the nose and keep it so that the airway is little not obstructed. But usually our patients are well tolerating, and we give Xylocard to prevent much cough reflex, or some short doses of fentanyl. And this extubation has to, and keeping in the post anesthesia care unit, usually done in sitting up position. And we have to monitor them for post-operative bleeding, which is the commonest complication. And sometimes stridor and hematoma from on the floor of the mouth can happen. So if that is happening and causing the stridor, as it is airway involvement, you have to immediately open up or take the patient back to the OR. And vomiting. But if patients, we are not doing here craniofacial syndromes and or obstetric sleep apnea, but if usually done if it is a tertiary care center, then they have to manage in high dependency units. Post-op nausea vomiting is found in 40 to 70%, which is the commonest complication, and the highest incidence is with Bimax surgery. Why it happens? It is a prolonged procedure, first of all. Then there is associative hypotensive anesthesia, higher blood loss, and the risk of ingested blood and surgical secretions. People also, young female itself is a risk factor for a post-op nausea vomiting. Anesthesia is also a risk factor. And we have to identify patients. One time we had a patient, she was a dentist and she knew everything about the thing, and she came for the Bimax surgery. So her main concern was post-op nausea vomiting. We have to assume and we have to explain her regarding the post-op nausea vomiting, and we told about the therapy what we are going through. Multimodal antiemetics we are using, like ondansetron and dexamethasone. So she was okay after that. So people do have, when they have read it about it, they do ask questions about how we are going to manage post-op nausea vomiting. So as I told, techniques to reduce. One of the techniques, intra-op, we can use TIVA more, that is total intravenous. Then administration of ondansetron dexamethasone, multimodal opioid sparing analgesia, and use of throat pack to prevent swallowing of blood. Analgesia, usually the surgery looks very strong, and but the pain is not that much, moderate pain, and we manage with the regular non-opioid analgesics. One of the most important reasons why they don't feel also pain is because we are giving local infiltration intraop with adrenaline, and they are blocking the nerves also. So ERAS, which is the enhanced recovery after surgery, which started with colorectal surgery, and now it is being, the principles are being applied in many other surgeries. And the principles being multidisciplinary surgery, we should have specific approach for early recovery and return to health with good pre-op counseling, optimizing the nutrition, standardizing the multimodal analgesia and early mobilization. So same current recommendations for controlled hypotension, these I have taken from the National Journal of Maxillofacial Surgery. And the goal is for 30% rule, and that is to reduce mean arterial by 30%, and map of 50 to 65 millimeters. They tell perfusion over pressure. If the surgical fluid is clear at a map of 70, do not lower it further. And there is a shift to hybrid hemostasis with tranexamic acid strategy, and this has been shown that 1 gram followed by maintenance has been found to prevent organ hypoperfusion with deep hypotension. Similarly, preferred pharmacological agents is remifentanil, dexmedetomidine. Magnesium sulfate can be also used. Nowadays, nitroglycerin usage is declining because of reflex tachycardia and with SNP, as we know, cyanide toxicity. One of the important complications from the surgery is the bleeding, which is life-threatening sometimes in one person. Why it happens? Because of damage to internal maxillary artery and its branches, most common cause. And epistaxis, if it is, will be there. Usually it is managed with nasal package, but if it is severe, we have to go for endoscopy and surgical exploration. One of the most important delayed bleeding is pseudoaneurysm. If the pseudoaneurysm bleeds, it's a life-threatening hemorrhage, and it is a very difficult airway because the patient is also in hypotension and airway is also difficult. So other complications can be infection and nerve damage. And in conclusion, orthognathic surgery is a transformative surgery. It is a multidisciplinary team needed, thorough pre-op assessment and planning, especially in challenging airways. And the most important thing which as anesthetist I have seen is that there should be a clear communication between the surgeon and anesthesiologist while he is doing which step, and we should be in parallel with the steps what they are doing, and the knowledge of surgical steps is vital. So our main anesthesia challenges are shared airway. We have to reduce the intra-blood loss with controlled hypotension, and we should be vigilant of the post-op complications. And induced hypotension is of benefit to patient outcome and safe when undertaken in an appropriate manner. These are my references. Thank you. This is the case done by Dr. Badar, and this is taken from his social media site. Thank you. Thank you very much.